Brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to a new episode of Health from Huda TV. Men above the age of 50, they start to be worried about the problems that prostate usually causes at that age. With us today is Dr. Ahmed consultant of neurosurgery, to talk to us about this issue. Dr. Muhammad, welcome to our new episode.
Welcome, Dr. Ahmed.
The prostate. Actually, most of the people don't know where is the prostate or what does the prostate do, but they usually worry about the problems they might face or that they're already facing. So, first of all, we need to know where's the prostate and what does it do?
The prostate is a gland situated just distal to the bladder neck. It's surrounding it surrounds the first part of the urethra.
Yes.
It's composed of three segments: the central zone, the interstitial, and the peripheral zone.
Yes.
It's the first 4 centimeters of the urethra. You can see in this picture.
Yes.
This is a picture here showing the prostate.
Yes.
This is a picture showing the prostate.
Yes.
Where it's compressing the urethra.
Yes.
First 4 centimeters of the urethra passing through the prostate. It's a gland present in all men.
Yes.
Here it is.
Yes.
You can see. This is a picture of hypertrophied prostate.
Yes.
This is where it is located.
The structure, the big structure, or is the
white structure. This is the bladder.
And
this is
it's at the base of the bladder.
The tube in the middle is the urethra.
Yes.
And this is the prostate.
It surrounds the.
And here you can see is the seminal vesicles here, right and left. Exactly. You can see it. It surrounds the urethra.
Yes.
The outlet of the bladder.
So yes.
This is where it is situated.
And what does it do?
The prostate, it secretes the seminal fluid.
Yeah.
The seminal fluid that nourishes the sperms itself. This is the function of the prostate.
Yes. So why is it always that many of the men at this age, of the age of 50, as we said, or usually above 50 and sometimes even earlier than this, have some problems with the prostate, or at least they're worrying about the problems with the prostate?
Dr. Ahmed, all men above the age of 40 or late 40s or early 50s, the prostate starts to enlarge. Yes. It's hypertrophied. In all men.
Hypertrophied.
Hypertrophied. It's hypertrophied. It means the cells itself increase in size, not increase in count.
Yes.
It's increase in size of the prostate.
Why does this happen?
Nothing we can say it's accurately the cause of benign prostatic hyperplasia.
Yes.
Some theorists say it's due to decrease the level of estrogen testosterone level. Some say it's due to enlargement in the cells. No definite theory, accurate theory for benign prostatic hyperplasia.
Yes, but the effects of the enlargement of the prostate on the urinary system and the reproductive system as well, sometimes it's dramatic.
Yes.
Yeah.
Not the enlargement of the prostate, not mostly cause symptoms. This is we should all people should notice there is no relation between the size of the prostate and the symptoms it causes. Sometimes we have prostate 30 or 40 grams. Usually the prostate is 20 grams, by the way.
Yes.
Sometimes we have prostate 30 or 40 grams, and it causes severe symptoms up to retention, obstruction. And sometimes we have prostate up to 100 grams, and it doesn't cause symptoms.
Yes. So what
it depends on the zones that enlarge.
So it's
Either it is the
the
central
area
zone
of
or
the
the peripheral zone.
Yes. Yes. Go ahead. So, yeah. So, it's the area where the prostate is diseased or enlarged
Yes.
that determines if it's symptomatic or not, and how bad it is that causes the pain.
That's right.
So usually what would somebody with an enlarged prostate, let's say the lay name of it, should expect? I mean, the symptoms.
The symptoms of enlarged prostate varies from one patient to another.
Yes.
We have a symptom score for the patients,
Mm-hmm.
either from asymptomatic or mild symptoms up to severe symptoms.
Mm-hmm.
Sometimes the patients start to have weak stream, double stream. He comes to the clinic saying, I have the urine coming in two ways.
Yes.
Weak stream. The stream was not like before. It's not like before. It starts to be weak, dribbling. Sometimes the patient has sense of incomplete voiding. After he goes to the toilet,
Mm-hmm.
he feels still, he has discomfort and he still has a little of
Needs
urine.
to go again.
He has to go again. The most annoying symptom is the nicturia. Nicturia, it means the urine has to wake him up from it.
Mm.
Sometimes patients have nicturia up to 10 times.
Is that because of the retention?
No, it's because of irritation of urine
Yes.
by the obstructed urethra. It becomes irritative.
Mm-hmm.
It's irritated to a few amount of urine. He goes, but he has few amount of urine.
Mm-hmm.
Also, one of the annoying things, one of the acute things that happen is acute retention. The patient is retained. The urethra is completely obstructed by the prostate, and he has to fix urethral catheter, start treatment, and then investigate the patient, and we see will he respond to medical treatment or not.
By retention, you mean that he cannot
He cannot pass urine
pass urine at all?
at all.
Yes.
And you examine his bladder, you found it's full of urine.
Uh-huh. So the pain coming from the prostate, is it always because of the retention?
No.
No.
Mostly the retention is a suprapubic pain, but pain in the perineum from the urethra, from the prostate, is caused by infection, infarction in a small part of the prostate.
Infarction is the death of the
Death
tissues.
of a part, yes.
Yes.
Infection, chronic prostatitis. We hear a lot about prostatitis. So I am having
Yes.
prostatitis. I'm having chronic prostatitis. This causes pain. But benign prostatic hyperplasia itself doesn't cause pain.
But somebody would have this this problem and would not have the pain, but still have other symptoms of the prostatic enlargement, like for example the infection.
Yes.
Would that take him to the to be alarmed and go to the doctor?
Yes.
Yes.
As we see in the next picture here, you can see this is a picture of, you can see it here, this is a
Yes.
picture of the normal bladder, and
Yes.
this is an enlarged prostate.
Yes, that's very
Okay, you can see here the bladder is smooth, there is no irregularity inside the wall. Here there is obstruction by the prostate.
Mhm.
You can see there is irregular wall, there is thickened wall, there is infection. We have residual urine, something we call residual urine. It means the urine that stays in the bladder after the patient evacuates.
Yes, stagnant does not go down.
Yes, and this causes recurrent urinary tract infection.
And it causes, of course, some irritation, as you said before.
Sure. Other causes of other symptoms of urinary tract infection, it's dysuria. The patient can experience dysuria, not also weak stream. The patient can experience dysuria and is mistaken with the urinary tract infection, the acute urinary tract infection.
Mm-hmm.
So prostate has many symptoms. The patient can present with many symptoms, but all we call lower urinary tract obstructive or irritative symptoms.
Yes. So a patient with these symptoms would come to you in the clinic, and of course you would do examination for the prostate, and you would do some investigation, and you have to know the problem, how bad the problem is. How would you systematically go through this management or the procedure of diagnosing the problem?
As we said first, history of the patient can guide you.
Mm-hmm.
Is the patient having obstructive or irritative symptoms, long-standing obstruction or nearby obstruction, the severity, the symptom score of this patient. We give symptom score from 1 to 18. That's it regarding the history. Then we start to investigate the patient. We have to examine, sure, the patient. We can examine the post-voiding residual urine by ultrasound, for example. We have to examine the patient per rectum.
Mm-hmm.
And this is an annoying examination, but we have to do it.
Yes.
For all patients who are having prostate.
Mm-hmm.
It's very important to differentiate either it is benign or malignant hyper.
Yes, that's very important, of course.
Okay.
And you can differentiate that even with the examination?
Not only,
Yes.
but it is one of the main important issues.
Mm-hmm. What further investigations?
Then you start to investigate the patient regarding his urinary tract system. You have to do ultrasound with assessment of the kidneys and the bladder, the post-voiding residual.
Mm-hmm. You have to measure how much urine output
Yes.
he has, and you get to know how much is left in there in the bladder as well.
You are right.
Mm-hmm.
And the effect of this obstruction of the kidneys, is there damage to the kidneys, is there dilatation to the kidneys due to this increase in the residual volume or not? Another investigation, important investigation, we have to do what's called PSA.
Yes.
It's the hormone of the prostate that elevates not only in malignant but mainly in malignant enlargement of the prostate.
Yeah, we have a short break, and we should come back and discuss more about the investigations
Okay.
for the prostatic enlargement. Brothers and sisters, we have a short break. Please stay tuned, and we'll be back in a short period. Until then, assalamu alaikum wa rahmatullah. Brothers and sisters, assalamu alaikum, and welcome back. We're still talking about prostatic problems, and with us is Dr. Muhammad Hatem, consultant of neurosurgery. Dr. Muhammad, we were talking about the investigations and how would we manage somebody who has a prostatic enlargement. We stopped by that you have to do a hormonal test,
PSA.
the
It's
PSA.
called PSA.
And
The
how important is this?
It's a simplification for prostate-specific antigen.
Yes.
It's a blood test, simple blood test. In all laboratories is present. Usually we have cut-offs for this investigation.
Mm-hmm.
Usually the patients shouldn't have PSA more than 4.
4.
4.
Yes.
If it is more than 4, we have to do more investigations for having cancer prostate.
Ah, yes.
Yes.
So this is where it comes to define either this is just a hypertrophy, as you
Yes,
said,
a benign hypertrophy,
benign
or
one,
it is a
or
malignant
it's a
cancer.
malignant one.
Yes.
Mm-hmm.
That's it. Another investigation, we have to do serum creat for this patient.
Serum creatinine.
Serum
That's,
creatinine for
to
this
see how
patient.
functioning how
Harmful is the residual urine for this patient.
because of the serum creatinine is to test the function of the kidneys.
Function of the kidneys.
Yes.
Yes.
Mm-hmm.
Sometimes patient is present with renal failure. And when we fix a urethral catheter, after a few days, this renal failure disappears. The kidney regains its function.
That's because of the obstruction.
Yes.
Mm.
That's it.
Do you have to take a biopsy from the
This is when we have an elevated PSA,
mm-hmm.
or when we are doing PR and there is query nodule, suspicious nodule, something like that.
You have to take a biopsy.
I have to take a biopsy, and it's done by transrectal ultrasound.
And it's not that painful.
Not that painful.
Not that painful.
Not that painful.
Yeah. So now that you have done most of your investigations, your situation now is either it's just a benign hypertrophy or enlargement, or it is a tumor. Of course, a tumor, you have to deal with it more aggressively than the benign situation. But for the let's shift to the benign side, which is more common, I believe. How would you manage this patient?
First, I would like to say there is nothing called protective surgery.
Mm-hmm.
nowadays we hear a lot of people saying, I am going to have, my doctor told me I'm going to have prostate as a protective. It's
Yes, we
enlarged,
hear this more
so
often
I
these
have
days.
to do surgery.
Yes.
It's untrue. This is completely wrong. We have indications for surgery, we'll talk about it.
Mm-hmm.
First, we start medical treatments for all patients, even if he has retention.
Yes.
We start medical treatment. There are many types of medical treatment. Something called alpha blockers, which start on smooth muscles. Something called finasteride, which start acting, but after a little bit longer time, on the fibrous part of the prostate. Then we show the improvement on medical treatment. Symptoms improvement, and if there is malfunctioning of the urinary tract, is it improved or not?
Yes, but when somebody has a prostatic problems, we usually hear that even if he is coming to complain of other thing, he tells you, I'm on medication for the prostate for life. Is it for life?
Yes, it's for life.
So when you stop medication,
for life.
You don't stop it.
It's daily treatment, like treatments of hypertension or diabetes. Can you stop treatment for hypertension or diabetes?
No, you should continue with that.
It's the same for the prostate.
Mm-hmm.
Nothing could regress the prostate.
Medically speaking.
Medically.
Yes.
Yes, we are speaking medically.
Yes.
So he should note he is going to have this treatment for life.
Mm-hmm.
If he is accepting, so that's good.
That's good. So usually the medication gives a good result with what kind of patients?
We can predict, but some patients who have the smooth or the stromal part of the prostate enlarged,
Mm-hmm.
they have good outcome with medical treatment. When the fibrous part is the main enlarged,
Mm-hmm.
there is a little bit improvement, or sometimes no improvement with medical treatment.
So how much time do you give for the medication to say, no, this is not working, we have to shift to another solution, or yes, this is going well, we should go ahead and proceed with the medication all the time?
According to the patient, we have emergency situation,
Mm-hmm.
as having retention, for example, or there is malfunctioning of the urinary tract,
Mm-hmm.
there is elevation in the serum creat, we should interfere.
Yes.
We can give trial for medical treatment. But all other patients, we have to start medical treatment. And we increase the dose of medical treatment up to reach the maximal dose. If there is no improvement, the patient is still complaining, if there is no improvement for the patient, we have to interfere.
After what time of period?
About
Of time?
2 weeks to
2
1
weeks.
month. Yes.
Yeah, to 1 month. So now somebody who is not satisfied with the medication, what's the next step? You go to surgery right away, or you have something in between?
We should investigate the size of the prostate. Size of the prostate differs from one patient to another and differs in our management, surgical management.
How would you know the size?
By the ultrasound.
With the
usually, by the
ultrasound.
ultrasound.
Okay.
Or the transrectal ultrasound, we can
Mhm.
use it.
Mm-hmm.
The patients having small prostates
Mm-hmm.
up to
Yeah.
100 grams, we can use what's called transurethral resection of the prostate. We can see here in this picture, this is how we enter with the cystoscope.
Mm-hmm.
We can see this picture.
Yes.
This is a picture showing, this is the loops of the prostate. You can see it
On the sides.
on the sides.
And you're going through the urethra
Through the urethra
with a scope.
by a piece of metal
Yes.
called the resectoscope,
Yes.
and we start to cut through this tissue and remove all this tissue.
But this does not have any effect on the urethra itself.
No.
No. Yes.
If the patient, we can see the other picture, this is showing, the other picture
Yes.
showing here is a piece cutted from the,
Oh yes.
You can
This
see
is
it?
a resected
A
part
resected
of
yes.
the prostate.
of the prostate.
And this makes the prostate smaller in size.
Yes, we can remove mostly whole the tissue of the prostate up to the capsule. We reach the capsule,
To the outer band.
to the outer band.
So, and this does not affect the function of the prostate.
No, there is no prostate anymore.
Yes.
After we do prostatectomy, either transurethral or open prostatectomy, there is no prostate anymore.
And how does that reflect on the function of the prostate?
There is no semen coming out. The patient should notice that if he is going to have intercourse, there is no semen will go out.
Mm-hmm.
Most of the semen, either as semen from the seminal vesicles also, will enter the bladder and then comes out with urine.
Mm-hmm.
That's
and of course, this would affect the fertility of this person.
Patients with more usual prostates, we use open techniques, or nowadays we use laser. There are different types of laser where we can use it to remove the prostate, and it's much more safer than what we said, the transurethral resection. There is no blood loss. We don't use we use certain irrigants which are not harmful, don't cause what we call TUR syndrome, some complications of the operation. It's much more safer, the laser.
And you go through the urethra as well?
Still through the urethra, all through the
same route?
Yes.
But still, you mean the differences in the how you resect
how
and how
we
much
resect,
you resect?
Exactly. The laser vaporizes the tissues.
Yes.
Resection, we resect the tissues.
Uh-huh.
But the laser, there is a rod, we pass it, and we vaporize the tissues.
Yes. So, what other ways to be able to treat the prostatic enlargement? Are there
We
any
said
other
if
ways?
it's a huge prostate,
Yes.
we can use the open surgery.
Yeah,
Which
that
is
would be a big
very rare
one.
to be used now.
Yes.
We usually use the advanced techniques.
Mm-hmm.
Well, we remove the whole prostate. Either we open the bladder and remove it through the bladder, or we open the capsule of the prostate and remove it through the capsule of the prostate. That's all.
Some of the patients who have the problem of the enlargement of prostate get to have some injection in the prostate. How often is that useful?
It's not injection in the prostate itself.
Yes.
If the patient is incapable for surgery, we use what we call minimally invasive techniques,
Mm-hmm.
like transurethral needle ablation, like cryo, like stenting of this part of the urethra, but we use it for the patient incapable for surgery,
Mm-hmm.
unfit for surgery.
Mm-hmm. So, by the end of this episode, I want you to give some advice to our audience how to avoid or at least delay the problems of the prostatic enlargement, and if they do have it, what should they do to avoid the major complications or problems out of it?
They should investigate early.
Mm-hmm.
People after age of 40 should do PSA early.
Yes.
Maybe every 3 years at the age, above the age of 40,
Mm-hmm.
every 1 year above the age of 50.
Mm-hmm.
Investigation, routine investigations like ultrasound should be held every 2 years at least.
Mm-hmm.
Any symptoms, any irritative or obstructive symptoms, what we said, lower urinary tract symptoms, should be investigated.
Mm-hmm.
Recurrent urinary tract infection should be investigated.
And treated, of course.
So, don't delay the management of your prostate. It will harm all the urinary tract. As I said, some people came with complete renal failure.
Mm-hmm.
So be cautious with your prostate. Treat it early. It will live longer with you.
Dr. Muhammad, thank you very much for being with us today. It's been a very informative talk. Dear brothers and sisters, I would like to thank you, and I hope it's been a beneficial episode this time. Our email is health@huda.tv, and of course our website is health.tv. We hope to hear from you, and until next episode, we wish you a happy and a healthy life, inshallah. Until then, Assalamu alaikum wa rahmatullahi wa barakatuh.